Okay, Ron, you're our presenter and I can see your slides.
Okay, I'm putting you on slideshow, I hope. From beginning. There. You got that?
We can
Hello?
see it well. Everyone's here and we're recording.
Okay, good. Well, welcome. I have had some interesting patients that I wanted to present to the group. And so basically there are some patients who have GVHD and have had coronary artery disease. The coronary artery disease looked kind of funny to me. And so I wanted to just present these patients, and then Iskra I will kind of go into GVHD briefly, and then I was sort of interested in everybody's comments on this and what they have seen. So basically we'll get right into the, see if this will work here. Let me get forward. There we go. Okay, so basically we're going to present 3 cases. We'll present 2 other patients who are going to be quickly presented, a quick review of the literature, which you'll see doesn't really exist very much, and then we'll discuss some of the cardiac issues. And my goal is to raise the awareness of this potential problem and think about approaches, because this is really something that hasn't really been discussed. So first patient is DL. He has a history of chronic myeloid leukemia. He had a subsequent failure of a TKI and a matched unrelated donor stem cell transplant in September 18, 2008. He developed extensive graft versus host disease of the skin, eye, liver, and gastrointestinal tract, as well as recurrent septic arthritis, and he ended up with an above-the-knee amputation with multiple recurrent admissions for sepsis and pneumonia, and he had positive respiratory syncytial virus. Presented with his heart admission, he presented only with decreased exercise tolerance over the previous 2 weeks. And the echo, which I'll show, showed an apical infarct with a large golf ball-sized clot in it. A myocardial perfusion scan showed a large apical infarct, and the coronary angiogram, which I will just show individual frames from to save time rather than the individual images, showed a LAD and a RCA occlusion, which were near occlusions, and then his cardiac risk factors showed a lipid of total 184, triglycerides 72, HDL 47, and LDL 123. His mother had coronary disease, and the key points of him was he had this thrombotic complication. It was a ventricular clot in an aneurysmal type infarction, a silent presentation of a large infarction, and then basically you couldn't even see calcification on the cath, which is true of these other patients also. And his arteries were smooth except for lesions in distal vessels. And Iskra Puzik has just come in, and she's worked with me as an oncologist who has an interest in GVHD. So we'll have her discuss this later. So here's a frame from the cath. And the thing is that I want you to see, which was striking in all these patients, is the artery is normal until it becomes very narrow, and then the whole thing is very narrow. This is the LAD, of course. Now you see the right coronary artery. Again, it looks normal. This is, unfortunately, a single frame doesn't show this full of contrast. This looks all smooth and gorgeous until you get to the point where it's totally occluded, and then the artery gets very small. And you see there are collaterals going up into the septals here and the LAD. But what struck me about him and the others is that the arteries that were not involved look pretty amazingly normal. Here's a frame from the echo, and it's just really full of contrast, and you see this big clot. And of course, it's much more dramatic when it jiggles around and everything. But it was pretty impressive. We treated him with warfarin and evaluated. His ejection fraction got a little better, and the clot disappeared. He's still on warfarin, as you can well imagine. So that's our first case. And the key thing here that struck me was that his infarct was totally asymptomatic. He had no chest pain whatsoever, and he presents with this obviously large anterior infarction. This is the second patient, who actually was the first patient I encountered. BT, he was 55 years old, quite dramatic. He was born in 53. He had chronic myeloid leukemia, which in an unrelated donor transplant in 2005. By 2008, he was in complete remission. He had severe GVHD and with small vessel involvement. He was on immune suppression with Prograf, Celsip, and prednisone. He presented in 2007 with orthopnea. He had no chest pain whatsoever. He was actually thought by the oncologist to have some kind of pulmonary problem, until, of course, you put your hand on his chest and you also heard this booming S3. He also had no peripheral pulses on examination. His ECG showed inferior and anterolateral infarction with ST segment elevation, T-wave inversion, a classic anterior infarction with aneurysm type of pattern. And again, we'll show these the CAS. The perfusion scan showed a large area of myocardial ischemia in the apex, which extended the anterolateral infraapical areas, a small fixed defect consistent with a small central infarction in the apex. His echo showed systolic and diastolic dysfunction. Ejection fraction was 25%. And we'll show the cath that showed all vessels with severe distal disease. And but the thing that was dramatic about him is that post-cath, and I figured I've done probably 25,000 caths in my career. He had a thrombosis of his diseased popliteal artery, which apparently was quite diseased, although his femoral was okay, and he ultimately ended up with an AKA. It's the only patient that's ever had that. Pathology of the peripheral arteries, we don't have a post on him, showed atherosclerosis, but there was no inflammatory process anywhere that could be seen in any of the arteries. His LDL was 152, and we treated him with ACE inhibitor, beta blocker, and Plavix. Then later he was admitted with hypotension, and he died in possibly septic shock, but no bacteria was cultured. And here are some pictures of his. And again, I'm not crazy about the way this shows, but I think the movies just took too long to show. Here's the left main, which was clean and looks nice. Here's the circumflex, which also looks good, but very distally it just turns into this skinny little vessel. It almost looks like what you'd see with a heart transplant. Pathology. This circumflex, there's another little disease here in this anterolateral circumflex. The whole vessel is skinny. There's not a focal lesion, and it's all distal disease. The LAD, again, it looks normal until it isn't normal, and then you see a high-grade lesion here, and then the distal vessel is very small, and then there's a diagonal you can sort of see here, and this all shows up very nicely that there's a long area, a very heavily diseased area, and then it never is large. So there were no targets. There is no opportunity for revascularization in this situation. Here's another view. This shows the iliocranial view, which shows you the circumflex. The large circumflex is an area here of more focal disease, and then the vessel kind of just disappears. This is the LAD, which is normal down to here, when again the whole distal area gets skinny. This diagonal, the whole thing is very small, and the marginal is, this looks a little irregular, but then it gets very small, and the distal vessel is very small. So it's a different pattern than you're used to seeing. The LV branch, a correction of the right coronary artery, again shows a large vessel, and then all of a sudden it gets very small and disappears. And here's the left ventricular branch of the right. The posterior descending artery comes around like that, and again, it's all distal, and the proximal part of the vessel looks pretty good. And this is our last patient that we'll see in detail, and she had a postmortem and was studied more extensively. She's a 58-year-old African-American. The other people were Caucasians, with a history of relapsed AML and hypertension, who was referred for, again, a new cardiomyopathy. AML was diagnosed in 2010. She was treated with induction chemotherapy, but she relapsed. Then she underwent a stem cell transplant in 2012, and then had an MUD transplant. She developed GVHD in 2003, which is really just a year later. And she was, you could see her across the room. I mean, she had really a terrible skin problem, and was really, but she continued to work. She was a very tough lady, and but she was just totally disfigured. It was just, it was really very sad. She presented in 5 of 2015 this year. She had, again, dyspnea exertion, absolutely no chest pain. The echo showed an ejection fraction of 35%, and the scan showed an apical infarct. She was cathed, and we'll show that. That 9 doesn't belong there. She had, in June, severe stenosis of the mid-LAD, and then there was subtotal stenosis of the distal LAD. The circumflex had a single high-grade lesion, and the right had mild atherosclerosis. So this was fairly focal, at least in the circumflex, and so the circumflex was stented. The LAD, as you'll see, this arrow just jumps all over the place, was ballooned, and there was a chocolate balloon, which is a balloon that's sort of encased in a wire cage, so it's sort of like the old cutting balloon. And that opened up and got a very smooth result. She returned in September, and okay. Can you guys hear me, by the way? I'm getting no feedback. Hello?
Yeah, we hear you well. Hear you well.
Oh, okay, great. I just was getting worried here. Returned in September that year, 3 months later, with chest pain, and the troponin was elevated. It was, I think it was around 3 or 4. The cast showed progression of the LAD and subtotal of the balloon segment. But then the echo now showed improved ejection fraction and the 25th, and then and this is what the cast looked like. Again, the right looks pretty normal. There's a little area here of disease, which I'll point out because of subsequent event. The rest of this looks pretty good. You know, the LV branch is along RV branch, which ends up in a little. I think this is normal for this vessel. It's really an RV branch. But here's where the action is. This is the LAD, and this is normal till it gets diseased. This doesn't look so unusual. But then what's unusual to me is then this then goes into the area of the infarct, and the whole thing is really skinny throughout. And of course, this can be seen as well. The circumflex is seen here, and this shows a high-grade lesion. It's sort of in a kink point. And so the LAD has this proximal lesion as we saw it, and then it gets really very poor as it goes into the infarct. So that what we did was we did stent this because it looked very severe, and this was ballooned, just ballooned, and then this was too small, nothing was done for that. We did a ICOS, which is interesting, and this was the circumflex lesion, and what you're seeing here is the, oops, let's get rid of this. Sorry. So what you're seeing here is this is really like fibrosis, and then the red is supposedly necrosis, but this is fairly normal looking atherosclerosis. It doesn't look unusual particularly, and that is the lumen. This area was ballooned, and you can see after the ballooning it looked pretty good. And this was the, so she returned in a month, in September. That was done in June. And here's the stent in the circumflex, which looks okay. And I hope I have another picture. Yes. And this is the area of the ballooning, which is completely restenosed. If anything, it's worse. And then the flow downstream was worse. This was just, and subsequently, but even at this point, she was doing better. This was she presented with chest pain for this second episode. It may be that that's when the LAD went down. That was the first time she'd really had a troponin elevation, and it wasn't very much. She returned a couple days later, and she presented with weak, and this was a very strange and severe and rapid course here. She presented with weakness, fatigue, chest pain. She was in cardiogenic shock, acute renal failure, severe acidosis. Her potassium was, I think, well over 6. She was lethargic, bradycardic. Her heart rate was in the 30s. The EKG showed a wide QRS and looked agonal almost, and a prolonged QT, treated bicarbonate to get the potassium down. And then she required intubation. She rapidly went downstream. We did get a postmortem, which was interesting. I was very interested, frankly, in these patients with GVHD to see, is there an issue with some kind of an inflammatory type of atherosclerosis or inflammatory coronary disease, similar to what you might see in a transplanted heart with coronary disease in that. But it was interesting and shocking. She had thrombosis in all of her vessels. She had acute thrombosis in the in the circumflex, right where the stent was. She had acute thrombosis of the LAD, which was occluded, and then she also had a thrombosis on that little lesion in the right coronary artery, which really was not even at all significant. She had, there were sections that were done, and I don't unfortunately have copies of those, but that showed severe stenosis with calcified atherosclerotic plaques, and there wasn't any lymphocytic infiltration. And we asked the pathologist specifically, and he did, look specifically for signs of inflammatory disease, and he saw there was none. This looked like standard atherosclerosis as far as he was concerned. There are a couple other patients I would just throw in here because, and this as far as I know is all that there is in terms of our contribution and what's in the literature. So we had a 43-year-old man who died suddenly 3 years after a bone marrow transplant for AML. Excuse me. And the postmortem showed a 75% left main and a 95% LAD, and everything was there, and it was, again, felt to be inflammatory, and he had a postmortem on that, and it was not inflammatory, and it looked like standard atherosclerosis. We had a 62-year-old woman, these are patients I wasn't directly involved with, who had a stem cell in 2007, a non-STEMI in 2014, and she had stented total circumflex, total mid-right, left main, LAD circumflex. I looked at her films, which I'm not showing, and they look pretty typical. They did not look in this other way where they had a normal proximal and severe distal disease. As far as I could tell, there are only 2 published cases of coronary disease in people with GVHD, and they're both in very unusual patients. One's a 19-year-old woman who died 30 months after a BMT with GVHD and severe coronary disease. And then there was a 25-month-old male who was diagnosed at 1 month with Wiskott-Aldrich syndrome and bone marrow transplant done at 4 months. He died at 25 months, and he had respiratory distress and rapidly had a cardiac arrest. Post-mortem showed rapid narrowing of all the vessels with severe to near total obliteration of the coronary lumens over the first 1 to 2 centimeters, the LAD, left circumflex, right coronary. The atherosclerosis was said to have a fibrous cap of newer connective tissue and concentric cellular proliferation, markedly narrowed the lumen of the LAD, and minimal increase in perivascular cells. Again, there really didn't sound like this was an inflammatory process, more of a fibrotic process. So those are the patients I'm going to present, and I'm going to ask Iskra to discuss a little bit about GVHD, and then we can open this up for discussion. So at this point, these are my observations. I don't know the denominator. How many people with GVHD are there that have coronary disease, and how many don't? The people that we had presented, they presented with heart failure. They did not present with coronary disease or coronary syndrome. The literature patients were quite young. There's no evidence of inflammation in the few postmortems we have. The disease seemed to be mostly distal, and the vessels were small. I should mention that woman that we did have up there had very small vessels. In general, they were all very small. There was no chest pain, and the adults did have high lipids, which are untreated in most cases. One fellow had his LDL was, I think, about 180, and again, this was not being treated. The focus of the oncologist was all about the GVHD. So here, I want to turn this over to Iskra, and she's in an oncology group and has been interested in GVHD and has a short presentation about that.
Hello, everybody. Good morning. So I will just say in really few words that GVHD can happen after allogenic transplant, either in the acute form shortly after the transplant, or later when it's called chronic GVHD. And that is this one period when you can kind of have elements of both of these diseases present. And all these cases that Dr. Chrome presented are really in classic chronic GVHD. In acute form, usually there are different cardiac problems, more some complications of radiotherapy or chemotherapy or infection. These are some of the manifestations of chronic GVHD, and most notably, this is severe skin sclerosis, mouth and eyes involvement, and also fasciitis, where there is significant limitation of a range of movement, and as well as lung disease. One thing that's not here is that chronic GVHD is also associated with serositis. So it's not unusual that these people can have pleural as well as pericardial effusions. And these pericardial effusions are not considered to be a cardiac disease per se, but more a consequence of serositis. So there have been, in the last 10 years, some movement in order to help diagnose and stage chronic GVHD. So there are some diagnostic and distinctive signs that are sufficient or helpful in diagnosing, and it's not supposed to be acute chronic GVHD. However, description of any cardiac signs are not diagnostic or distinctive, but they fall under the category of other signs that can be acknowledged as a part of chronic GVHD, but are not commonly seen and are not necessarily diagnostic. And cardiac manifestations, the reports of cardiac manifestations are rare, and they are somewhat controversial and mostly diagnosis of exclusion. And there is a lot of overlap with other cardiac disorders, and it can be potentially a consequence of chemotherapy, infections, high blood pressure that can be somewhat confounding. The number of reported cases is really very small, and they are described as some bradyarrhythmias, heart block, CAD, and cardiomyolysis. So there is several components why is this happening, and one is that there can be endothelial injury, and the other is that in the absence of this lymphocytic infiltration, the question is whether cytokine release that's so common and prevalent in GVHD could have an effect on development of cardiac disease in GVHD. So I will kind of stop here, and there are these two cytokines, TNF-alpha and IL-2, that are commonly elevated in chronic GVHD that are known to have a role in cardiac disease. And, so the question is here. I will pass.
Okay, so basically, in terms of our presentation and for the conversation, the question is, the severe coronary disease is seen in these people, but we don't know if this is unusual or this is just the natural history of coronary disease and two diseases in the same demographic. And then, is there a risk of severe disease, or is there an increased likelihood for thrombosis that may occur? I mean, certainly it was very unusual in the third patient when she had thrombus of all of her coronaries, of course, at a time of catastrophic shock for whatever reason. And then, is this a place to make a statement to talk about modifiable risk factors in more stronger terms, which is sort of one of the things that we have as a group been trying to get forward. And then it seemed to me there was a need for more information, and then obviously we have to agree that we can't draw conclusions from what we have available here. So at this point, I'm going to put us on speaker here so we both can contribute and then listen to whoever is on the line. Okay, we can hear. Can you hear us now?
I can hear you well.
Okay. So I'll just open up for comments here. Who's here, by the way? Besides you.
Joe Carver. I unfortunately joined late in the GVHD discussion, so I missed the essence of the case. Sorry.
Oh, okay. Well, there are basically three unusual cases with normal-looking proximal disease and then very severe skinny distal disease. And that was sort of what my interest as to wondering whether this was a unique presentation of coronary disease in these patients. Hi, Joe.
This is Barry Trachtenberg from Houston Methodist Hospital. I'm listening in a very interesting conversation. We recently had a patient with GVHD that died on the heart transplant waiting list and had an acute MI and came to the hospital severely sick and ended up dying of multi-organ failure. And I'm wondering if anyone else has experience successfully doing a heart transplant in patients with GVHD.
Doesn't sound like it.
No, we don't have, I don't think we have any transplant cardiologists here, so I can't comment on that. But we'll invite transplant cardiologists next time because of this topic.
Yeah, Eric, this is Brian Jensen from UNC. I am one of the transplant cardiologists here.
Glad to hear.
And the brief answer to that question is no, we have not transplanted anyone with GVHD.
So that's really interesting. Are there any markers that you can follow for this disease? Is one thing, and the other question is, has anyone ever done some serial CT scans to interrogate the vessels and get more information on the plaque composition and how that changes over time? We've been doing plaqueograms here where we'll do serial images of a single plaque with one gantry rotation, which gives you a radiation exposure of 0.5 millisieverts, and you can follow a plaque over time. So does anybody have any observations from CT scan of these plaques?
None here.
None. I mean, the experience here has been really that our oncologists are not really thinking cardiac or coronary disease in these patients unless they have symptoms.
And interesting is that most of these patients were actually asymptomatic. This one young man presented with essentially sudden death. He was young and he didn't have any cardiac symptoms. And some of the other patients were also free of chest pain, didn't have any particular risk factors, and had a lot of other issues considering their GVHD on their plate, that it's not that it was an oversight not thinking about heart, but they just were completely asymptomatic.
To me, that was
Go ahead.
the striking thing about them all, is that they presented with a silent, large heart attack and severe LV dysfunction. I mean, one guy had this aneurysmal situation with a large clot in it. You can't say that was an unusual clot because that type of aneurysmal infarction is prone to clot, but still, it just seemed a little unusual.
So any experience with any inflammatory markers in following these patients in terms of their systemic disease?
So there are some, and it's mostly the area of new development of trying to find biomarkers for chronic GVHD and then to try to follow them or potentially target them. There is nothing that's proven as a known biomarker. There are some that are under investigation, but nothing that we known as a classic biomarker.
I see. We've been following some inflammatory biomarkers that have to do with apoptosis, either up or down, and have to also do with macrophage migration. And so there's a test, used to be called the MI risk evaluation, that's now called the PULSE test, PULS, that basically has 7 inflammatory markers. There's interleukin-16, there's hepatic growth factor, FAS ligand, SFAS, CTAC, eotaxin, MCAP, and these are all inflammatory markers. You can get that in Irvine, California from Global Discovery Biosciences, and I've been using it for identifying patients who have vulnerable plaque and have vulnerable disease because of their inflammatory markers. And so it would be interesting to apply that to some of these patients, see if that would be helpful. I find patients with progressive coronary disease that are 5 to 6 times normal with these markers. These markers were tested with a MESA group of patients from NIH and also tested with the Marshfield Clinic group of patients in Wisconsin, and that's how they became pre-selected among 200 biomarkers. These were pre-selected as the ones predictive of cardiac events in the future.
So I'm wondering if anyone out there, for those of you that are seeing these patients from the cardiology side prior to stem cell transplant, are you doing, what kind of routine cardiac evaluation are you doing on these patients? And curious if you're collecting that data.
You mean before they go to transplant?
Before they develop GVHD, just for risk stratification for patients that are going for stem cell transplant. Because we see a lot of our bone marrow doctors are sending us patients to kind of risk stratify the patient before undergoing their bone marrow transplant.
And the only test that we routinely do before bone marrow transplant is an echo or MAGA.
Eric, your turn.
Yeah, the patients we have sent for evaluation here, if they're sent for any evaluation for cardiac disease in terms of cardiotoxicity in the future, basically we get a baseline coronary CTA, males over 40, females over 50, as part of our routine evaluation. We'll be presenting that data in the future.
Look forward to hearing that.
This is Brian Jensen from UNC. I actually discussed this very issue with Dan Lenahan and Javed Moslehi recently, and they traditionally do just clinical evaluation, EKG, and echocardiogram.
Yeah.
It's sort of a lot of transplants, and I see a large majority of them in the absence of any other reason that I would do a stress test, that I would stress or image. We don't look at the coronary anatomy pre-transplant.
We were able to get a special pricing for coronary CT because we do limited radiation exposure, and so it's just a 10-minute test with step and shoot and iterative reconstruction, and so there's no post-processing required of the tech. They just bring us the disc or shoot it to the cloud for us, and so we were able to get special pricing of $199 for that test since it's just a 10-minute test, and so that's made it very helpful because we don't have to go through the insurance companies and ask for an appeal and all the other stuff you have to do frequently. And with the $199 pricing, patients are willing to pay out of pocket.
Yeah, so the insurance issue in Philadelphia is really outrageous and virtually impossible to get a CTA for almost any reason from our local carriers. I brought up your idea to the administration here about reducing the cost and hit a brick wall.
Yeah, what did they say? What has the administration said to that, Joe?
Yeah, they were not interested. I mean, I told them that you don't process it, that you guys really do all the work, and it just hit a brick wall.
Yeah, I'll be glad to go with you and fly in and present some data to them and show them how it's very cost effective for a hospital because, one, the patient becomes more familiar with that hospital and allied with it. Two, there's a lot of spin-off when you find nodes and so on and so forth on the scan, and it's a way of generating customers. I know a lot of places do calcium scoring with a special deal of, I've seen $59, I've seen $99, and those are deals to basically introduce patients to the hospital with affordable screening testing. And so this is not unlike that, except it's a little more complex test, but it's a quick one, and the post-processing is so abbreviated that the hospital says, hey, that's fine. So I'd be glad to come talk to a CFO or somebody or do an online conference, and we can have our CFO come in if you'd like.
All right, maybe we could do this like as a video conference, and you don't have to show up here. Let me see what I can do.
The decision is mainly marketing and CFO, and as opposed to CEO or COO, it's a marketing CFO decision.
Okay.
Getting back to this problem, I mean, do you think, that as you see it, do you see that this is a special, unique situation, or is this just good old coronary disease that happens to be in people that have GVHD? I mean, obviously the 19-year-old and the 25-month-old is a little exceptional, I'd say. But the others, I'm not sure how you can distinguish it. And also, I'm not sure even with early identification if it would have made much difference if all the disease is distal, as it appears to be. To me, the only thing I can get out of this is that we should be treating, looking for cardiac risk factors and treating them more aggressively in these patients. Although the data is certainly not totally enough to justify it. It's more a matter of risk-benefit sort of thing.
Well, Eric, I want to ask you, what do you do with the data after you ultimately screen everybody? Does it stop people from getting transplanted? Do you intervene and what do you do with the information you gain, and how does it impact the transplant process?
This is Eric. Are you asking me about the coronary CT?
Yeah. So somebody gets a coronary CT prior to bone marrow transplant. How does that?
Well, that's for us. That's an evaluation of risk, and so frequently you see people with entirely normal coronaries, and so basically no coronary calcification and normal coronaries. They actually have a 15-year warranty according to the literature, and then we see people who have a single or focal, very few scattered nodules where basically they're calcific and remodeled, and we consider that inactive disease from someone who had an inflammatory reaction of some sort and then basically calcified the vessel, which is the area, the focal area, which is sort of the end stage of first lipid and then fibrofatty and then fibrous and then calcific. So we feel that's sort of the end of story of a lot of people, and so that's not considered a problem. And then when we see mixed plaque and we see calcium embedded in plaque that's fibrous, that has necrotic core and so forth, that's a more interesting area that takes a lot more concern, and we actually evaluate those people with the pulse test for inflammatory markers, and we also, and sometimes if it's in the 50 to 90% range of stenosis or obstruction, we want to know if there's a flow problem, so we either get an FFR from the CT if available, or we do a functional test such as a flow test. We have several MR tests that are functional. We have one is called Sync that we can do with a single heartbeat and stimulate with dobutamine. We have another one that's a flow, dynamic flow, first pass study, and color-coded and so forth that can be post-processed. And so we see if there's any functional abnormality downstream of the obstruction. And then this is factored in our taking care of those patients in terms of, are we worried about their substrate of significant coronary artery disease or moderate coronary artery disease? Do they have expressions of vulnerable plaque? And we have to keep an eye on those plaques as we go through this process to make sure that there's not evolution of coronary disease. And what we're looking for mostly is calcification of vulnerable plaque and fibrosis of vulnerable plaque, so that it moves on to be a plaque that's not as risky of rupturing, that may end up producing some greater stenosis. But we monitor for that with these plaqueograms, where we can do a single plaque picture and follow up on that with low radiation, 0.5 millisieverts. Does that explain what we're doing?
Where do you have a series then of people that you've done this who end up with GVHD, or you probably would have gotten it with an original pre-bone marrow transplant evaluation rather than, in the midst of a GVHD.
We've not had the opportunity to investigate GVHD, but would love to cooperate with you to look at that, because that's an unexplored area. I think you ought to publish these cases, and certainly raises a lot of questions, and it would be a lot of fun to put together a protocol for evaluating these patients. Be interesting to know the numerator and denominator that you have here, and how many patients you have to screen before you pick up somebody. Also, be interesting to know if there's some subtle disease that we're missing, that if all these patients are having some disease, but some of them are more reactive than others.
The striking thing about this actually is it doesn't look like the plaques are that vulnerable. I mean, the people that had the infarctions, the vessels were actually not obstructed like you'd expect if it was a vulnerable plaque with thrombosis. They just were narrowed. And, it's possible they were recanalized, but you could never see a focal area where there was a significant lesion. The whole thing was narrowed after a point, but there wasn't a focal place with some disease beyond it, except perhaps in the last patient presented. But in the other two with the silent big infarctions, the vessels were really narrowed, but you wouldn't even see that this would be an infarction in that one guy with the clot, for example. Usually you'd expect to see a total occlusion of the LAD or something, and he had an LAD. It was open, but highly narrowed. And then the vessel itself was very diseased distally, the whole thing. So it was unusual in my experience.
No question. It's a totally different disease in terms of that kind of presentation. It'd be interesting to see what galactin-3 is, check some fibrosis markers, wanting to know if they would respond to anti-fibrosis like spironolactone, or if they respond to anti-inflammatory like colchicine or methotrexate. But there's no question that you're looking at a different disease. Did you give them nitroglycerin routinely to see if those vessels would dilate up any?
Yeah, during the cath, several were done with that. It didn't make any difference.
Yeah, to me it seems very analogous to the patients we see that post-heart transplant that develop coronary allograft vasculopathy that's immune-mediated, and it seems like a pretty analogous process. And at least speaking from here at Methodist, we see a lot of patients that go for bone marrow transplant. If you guys are interested in putting together a protocol where we're doing pre and post CTAs and want to increase the denominator, we'd be happy to collaborate with that.
That's great. I think we need a protocol. Also, be interested in any of the patients were they all in Plavix, or were they taking Brilinta, or were there any Effiant, or what kind of drugs were they getting?
Most of these patients, actually all of these patients, I know every single patient that was here presented from WashU, and they all had very, very severe chronic GVHD. So it's not that it was only their heart. They had multiple other problems. So all of them were on high doses of immunosuppression. Some of them also had borderline platelets. So I don't think that any one of them was on Plavix.
No, not worth.
Because they were just not able to tolerate antiplatelet agents. So it would be hard to keep such patients on Plavix, and that's why it's also hard to catch these patients and then keep them on antiplatelet agents afterwards, because they have all these other comorbidities coming from GVHD and low platelets that kind of prevent that in a way.
This is Brian Jensen from UNC. Quick question. So again, want to echo the thoughts that this looks for all the world like allograft vasculopathy, just from the perspective of a heart transplant guy. We treat allograft vasculopathy with Rapamune. What's the role of Rapamune in treatment of GVHD these days,
we use it,
if any?
We have a lot of our patients on Rapamune.
Yeah, it'd be interesting to see how or if that affects the progression of the coronary disease. Obviously hard to do with such small numbers, but there's a literature to support that in heart transplant vasculopathy.
What is the pathology? I'm sure you must see some pathology on the heart transplant vasculopathy. I mean, what is that? I'm not that familiar with it, but I know when talking with heart transplant people like Greg Ewald, I mean, he thought there was also a correlation, or at least it seemed that way. But that's why it was so surprising to look at the postmortem and see there was really no inflammation. It was all regular old atherosclerosis, perhaps more aggressive. That's hard to say, of course. But the actual lesion, at least on H&E, or I don't know how the staining and all that went. It certainly wasn't done on electron microscopic evaluation. But but looking for a lot of inflammatory markers, there were none.
Brian Jensen again. Oftentimes the transplant vasculopathy is more of a hyperproliferative process, even more than an acutely inflammatory response. And it does not preclude acute coronary syndrome, thrombotic acute coronary syndrome. We've lost a couple of patients who had chronic allograft vasculopathy to the sort of massive thrombotic MI that you described for one of your patients.
Yeah.
So the transplant vasculopathies are frequently upstream as well as downstream, and so proximal disease is very common. So this is much different in terms of being more distal disease. So that's a curious finding.
We'll have to look and see if these were treated with Revlimid. I'll do that. But as Iskra was saying, they probably were because they all had
Revlimid, you mean?
Revlimid, yeah, because they all had very severe, at least skin lesions, and other problems from it. These were not minimalistic problems. They had major GVHD, and this was a major part of their morbidity.
So you're saying this is accelerated atherosclerosis like you see with HIV patients?
I don't know. I mean, that's the question. That was sort of the interesting, but it struck me that at least on the gross, meaning the angiography, it did have certain resemblances to the post-transplant heart transplant vasculopathy.
Yeah, the distal pruning is not at all uncommon. That's pretty typical.
Mm-hmm. That was our impression. It was just surprising that at least in the one postmortem, we only had one of the three, that there really was we didn't see that. We really just saw fibrosis and no real inflammatory process.
It would be interesting to do intravascular ultrasound during the diagnostic angiograms on these patients to see the nature of their kind of the pattern of atherosclerosis and plaque.
Yeah, well, we did one with the volcano and these presumed tissue Doppler, but basically it didn't appear to be anything unique. It looked like plain old what they ordinarily would see in any from any lesion, basically. That was sort of surprising. It was eccentric. It wasn't. I would have thought it would have been more concentric. It looks concentric on the echo on the cast, but when you look at the ultrasound, it was clearly mostly eccentric. There were some concentric areas that were with severe, concentric fibrosis, but much of it was eccentric.
Let's see, Dan Linehan couldn't attend today, but he sent an article that he wanted me to allude to that's from Cardiovascular Catheterization and Cardiovascular Intervention Journal. That's an expert consensus statement on patients with cardio-oncology and cardiac catheterization laboratory that was endorsed by the Cardiological Society of India and the Latin American Society of Cardiology Intervention. And so I just wanted to mention that he sent that, and anybody who's interested in that, we can send that on to the membership.
I'd like to see it.
It's really excellent, very detailed, 22 pages, references.
Yeah. Great, I'd love to see it. Yeah.
Okay, we'll send that to you. So any other questions or comments from those who haven't spoken? Sebastian, any comments from your place?
There will be at NIH in June a conference that's put up by Steve Pavletic, who is a chronic GVHD man there, and it's a conference on late effects, and there will be some cardiologists from NIH, I think Lung and Blood Institute, that are going to be, I think, presenting some aspects of cardiac involvement.
That'll be very interesting. Maybe we can put something on the agenda for the International Cardio-Oncology Society North American meeting in Vancouver, September 29th and 30th. Maybe we can get something on there about this. This would be great for you to make sort of a presentation about this. It's very interesting.
I was struck by it. I really appreciate everybody's comments.
We had a lot of time to gather some more data before that conference next September, so maybe we can get some more stuff and have you present this. It's really interesting and deserves more national attention.
Yeah, I thought so. I thought it was an interesting observation. I was very interested in, the contributions of our group here on the webinar. And I appreciate that. Thank you.
Sebastian, did you have comments about this?
I have no experience in this area, but I would like to send my congratulations for authors, especially for Ron. Congratulations once more.
Thank you.
Thank you so much. This was an excellent presentation. That is an unexplored area. I think we should come up with our own protocol and work together on this. I think we also should show it at our international conference. And so I'd like to thank Ron for his contribution today. A very excellent presentation. Certainly raises a lot of great questions. Thank everybody for coming. And some of our new attendees today from Sarah Cannon. We want to thank them for coming to our conference. And we appreciate everyone's contribution and attention.
I want to thank Iskra especially, Iskra Puzak, who put together her presentation and really lent us a different point of view.
So she's saying.
Thank you so much, Iskra.
Nice to meet you here. Thank you.
We'll see you next month for the second conference of the year, which the second Thursday at 9 a.m. Eastern Standard Time.
And I would like to invite everybody to enjoy Onco Review journal.
Okay.
Thank you so much, Sebastian. It's a great contribution, great journal.
Thank you.
Hi, Brian, Barry, Carolyn, Daryl, Izzy, Carinza, Sebastian, Sybil. Thanks so much for attending. We appreciate it.
Thank you.
Thanks.
Take care. We'll see you next month. Thanks.
Thank you.